Hi, I'm Mark Krieger, President of the American Heart Association.
Hi, I'm Kim Williams, President of the American College of Cardiology.
We're here in London at a meeting of our sister society, the European Society of Cardiology, and it's been a terrific meeting. There's been a great number of outstanding and very informative late-breaking clinical trials that I think is, I'm sure you would agree, Kim, is extremely valuable to cardiovascular practitioners and physicians in general. What were some of the highlights for you?
Well, the overall meeting has been spectacular. It's very high-level science and very applicable to the bedside. Yeah. And so folks will be very excited to see what works and what doesn't work. I was actually pleased to be part of a session as a co-chair and invited by ESC to look at their hotline sessions. There was one that really dealt a lot with myocardial infarction, specifically about remodeling. And there were 5 different approaches that unfortunately turned out that didn't do much. But it's good to know that there are some things that probably shouldn't be really pursued much more. One of them was actually the PROMPT trial presented by Greg Stone, with the concept being, let's pace the dysfunctional area of a myocardial infarction so that it has early activation, has less afterload, and won't remodel badly. Unfortunately, it didn't work. We had several trials, such as pharmacologic intervention, some designed to try to reduce remodeling by getting rid of reactive oxygen species and preventing reperfusion injury. Still, none of them actually worked.
Well, negative trials are important, though. It certainly informs us. And if we don't do the trials, we don't realize that some really compelling hypotheses have not been proven correct.
That's right.
So I learned a lot from those trials as well.
Indeed.
But there were a couple wins for electrophysiology, and these were in Hotline 2. One of these was the leadless 2 trial, which was looking at a pacemaker which was more or less implanted in the right ventricle through a catheter that was inserted through the femoral vein. The catheter is removed, and this pacemaker, which is barely the size of this pencil, half of it, is left in place in the right ventricle. And what that does, of course, is eliminate the need for an electrode to be persistently in place across the tricuspid valve. So imagine all the potential advantages.
Indeed.
And the safety and efficacy seemed very good, so real promise there. And another electrophysiology win, if you will, was a study that looked at the electrical isolation of the left atrial appendage. So it's not mechanical isolation, it's done electrically, in addition to pulmonary vein isolation in patients with persistent atrial fibrillation. And in that trial, the group that got the electrical isolation of the left atrial appendage had less recurrent persistent, less recurrent atrial fibrillation.
Indeed.
Yeah, so that was important. Of course, the underpinnings of that is there still will be a need for anticoagulation therapy in those patients because some of that group still did have recurrent atrial fibrillation.
Indeed.
So that was a good one. Another interesting group of trials came forth at Hotline 3. 2 of them had to do with patients with diabetes and using some of the novel drugs, the incretins, so GLP-1 agonists or the DPP-4 antagonists, which increase levels of incretins. And in each of these trials, they were really looking at whether these agents caused harm or increased risk of adverse cardiovascular events in patients who had diabetes and cardiovascular disease. And the good news is that they didn't increase the risk of these adverse events or the incidence of congestive heart failure. And you'll remember, Kim, recently the FDA added labeling to non-steroidal anti-inflammatory drugs, warning us of the increased risk of adverse cardiovascular events in patients who take these chronically. So one very important study compared the COX-2 inhibitors, or a COX-2 inhibitor, with the use of a more non-specific non-steroidal anti-inflammatory drug. And there was really no difference in adverse effects between those 2 groups. And actually there was a lower risk of adverse events among patients who are at high risk for these events, lower than we might have anticipated.
Well, that's good news because they're certainly widely utilized.
They are, and as we've both discussed recently, we need to make sure that our patients are aware of the possible problems with these drugs, so they don't get them or don't take them for too long a period. And you know, if I can go on, because there's another interesting group of trials and a hotline session that had to do with high blood pressure.
Indeed.
And one of these studies looked at patients with resistant hypertension and was examining the efficacy of mineralocorticoid receptor antagonists, aldosterone antagonists, in patients with resistant hypertension. And there's been some small trials here, but this trial, which came from the British Heart Foundation, or was sponsored by the British Heart Foundation and the National Institutes of Health Research here in Great Britain, did demonstrate that when added to usual treatment for hypertension, renin-angiotensin system inhibitor, calcium channel blocker, and a diuretic, so patients that really make the definition of resistant hypertension, found that spironolactone was a very effective treatment in lowering blood pressure, particularly when compared to a beta blocker or an alpha blocker.
That's important news.
It is. And you remember last year at this meeting there was a trial that looked at the combination of a neprilysin inhibitor and angiotensin receptor blocker in patients with congestive heart failure, which showed some very favorable effects. Well, this year the same drug combination, so angiotensin receptor blocker, neprilysin inhibitor, the acronym I'm told is ARNI. ARNI, new class of drugs, was very effective at reducing evidence of vascular stiffness in older patients who had systolic hypertension.
Really good news.
So real promise.
Parameter trial, absolutely. All right.
So a lot of good things here at the European Society of Cardiology meeting.
It's been a good meeting.
All right.
All right. Thanks.